Welcome to episode 57, an intro to body-focused repetitive behaviors. They're more common than you'd think. Featuring Dr. Laura Chackes, licensed clinical psychologist, from Clearly Clinical. Learn, grow, shine. Hello, and thank you for listening today. I am excited to be here with Dr. Laura Chackes, who is a licensed clinical psychologist, and she has a specialization in treating children and adults in anxiety disorders, OCD, and other related disorders like body-focused repetitive behaviors using cognitive behavioral therapy and mindfulness. Laura, thank you for joining us today and for sharing your expertise. Tell us a little bit about your background and how you came to do what you're doing.
Sure. And thank you for having me. So I started treating OCD and anxiety disorders about 13 years ago when I started my practice. And I continued, treating those. As I was treating those disorders, I started seeing people with trichotillomania, and also known as hair pulling disorder. And so I was treating that the same as OCD and talking to my supervisors at the time about it. And they asked me if I wanted to specialize in trichotillomania because the place I was at didn't have anyone who specialized in that. So I jumped on that opportunity because I always love a good challenge. And I also thought, it was interesting. I was interested in the patients that I did have with that disorder. So I really kind of fell into that specialization, but have really learned to love it. And through the years, it's been a big part of my practice. So I've continued getting training. I go to and now present at the TLC Foundation for BFRBs. They have an annual conference, and that's always a highlight of my year each year. So I've really taken that into my practice after I left where I was working at the time, St. Louis Behavioral Medicine. I went off into private practice for a few years, and then I founded the Center for Mindfulness and CBT in 2016. And that's where I currently work as a psychologist and continue to specialize in those disorders.
Got it. Well, thank you for being with us. Tell us kind of first to start off with, what is a body-focused repetitive behavior?
That's a great question. And actually, it's kind of funny because so many people have never heard of it. And I'll mention, I don't even say BFRB anymore because no one knows what that means, even therapists. But even when I say the whole thing, body focused repetitive behaviors, I just get this blank look or like, what is that? So it's very surprising how many therapists, counselors, doctors, school counselors, everyone that should know about these disorders don't. So I'm glad we're talking about this. But so basically BFRBs are a group of disorders that relate to some sort of repetitive behavior directed at the hair or body. So the two most common ones are hair pulling disorder, also known as trichotillomania, and that one has been in the DSM for many years. It was in the DSM-4. Maybe even before that, but that's the first one I used. And then skin picking disorder, also known as excoriation disorder. That's what it's called in the DSM-5 when it finally made it to the DSM in 2013, which is a big day for all of us BFRB therapists. And then it's also referred to sometimes as dermatillomania. So that was what it was kind of called before it got its official diagnosis. But BFRBs can also include chronic nail biting, chronic thumb sucking, cheek biting, lip biting. So it's any kind of, like I said, some kind of behavior that's done repeatedly that causes some kind of physical damage to the skin or hair or some part of the body. So, and just a note on the nail biting and thumb sucking, because people always ask this, well, it's so common, so are babies who are sucking their thumbs, is that a BFRB? So no, just as, all of us in the mental health field know that it's only a disorder if it is out of the norm and it's causing significant distress or disruption in functioning. So nail biting is rarely seen, and I have very rarely seen it in my office. It's only if they are biting so badly that they're getting like infections or their nails are all red and it's, really causing them a problem in some way. But just kind of regular nail biting, usually people don't come in for that. Same with thumb sucking. Where I've seen it, actually, I have a client right now who's 17 years old and she sucks her thumb. So obviously, that's a problem. A 3-year-old, not a big deal, but so that's just kind of where we use discretion as a therapist to whether it's actually a disorder or not.
Got it. So it is one of those things that falls on that continuum, like the DSM in general, of kind of shades of normal and then where things cross over into that line of being clinically relevant. Um, so how are body focused repetitive behaviors diagnosed? How do we see it clinically? What should we be looking out for?
So you sometimes will see it as far as someone who has on their face. You may see more excessive like scarring or actually I should say actually like open wounds or scabs. So that it looks like, more excessive than somebody who just picks at acne every once in a while, but someone who's really digging in there and making bigger marks. Or you might see like kind of almost like polka dots on their arms or legs, whether it be like scars or fresher scabs. People often will pick at mosquito bites or ingrown hairs, things like that. With the hair pulling, you may see a bald spot. You may see some missing eyelashes or eyebrows. However, most of the time, the people who have BFRBs have become very good at hiding them, and so you won't see it at all. Even the people that excessively pick at their face, they are very good at hiding it with makeup. Very good at hiding it with clothing. I mean, one thing you may notice is if in the summer, if where you live it's warm, like here in St. Louis, and they're wearing sweatpants and a long sleeve shirt every day. I mean, of course, that could be other things as well, but sometimes that's a way that they're covering it. And the hair, yeah, they have, same kind of thing. They will maybe cover it with a hat or scarf or something like that, but often hair pieces, hair extensions that we can't even, tell. So I think that we should all ask about it. It's a simple question just to say, just like we ask about other disorders, just to say, do you ever do any repetitive behaviors to your body, such as picking at your skin or pulling out your hair, more excessively than you want to be doing? And that simple question could often get people to acknowledge it. But however, they also may still at that point not acknowledge it. Another thing I do that I think really helps is I have brochures in my waiting room that are talk about body focused repetitive behaviors so that people know that I treat those disorders. And sometimes I'm hoping that they'll see it and that will make them more likely to bring it up when they start to read more about it. Because just like I said, most professionals don't know about BFRBs. Most clients don't either. They've never heard of it. A thing I hear a lot is people will say, well, oh, I've been suffering with this for 40 years and I never knew there was a name for it. And that's really can be an emotional thing because once they figure it out, they are just there's such relief just in getting a diagnosis and knowing that they're not alone. So they just go to great lengths to hide it and cover it up, and they may not even admit it to you because there's so much shame, guilt, embarrassment associated with these disorders. So I say ask, and maybe keep asking if you think that might be happening, even though they're not admitting to it. That's my best advice with that. And I think also if we can kind of spread the word, that's one of the things I'm trying to do is every time, if I go to the dermatologist for myself or take my son to the pediatrician, I'm mentioning these disorders. I try to throw it in there just to let them know, I treat these disorders. It's a little bit of a marketing technique, but also a really good, I want to spread awareness everywhere I can. I'm doing it all over social media because that's one of the reasons I've become passionate about treating these disorders is it's really sad how people just don't know they exist when they're actually way more common than a lot of disorders. So the current estimates are about 1 in 25 people have a BFRB. So every classroom, there's a kid with a BFRB, but you ask a kid and they'll say, no one in my whole school does it. And, it's just not true. They're just hiding it.
That's really good to know, especially with the frequency. How do BFRBs present with other diagnoses? I know for me, coming from a substance use treatment background, of course, we see skin picking disorders not disorders, but symptoms depending on what substance someone might be using. How does it present in concert with other behavioral health disorders?
Oh, that's a great question too. Yeah. So with the substance abuse, that's one area I really don't specialize in, but a couple of comments on that is that, as you mentioned, that the skin picking sometimes can be a symptom of drug use, and so sometimes people will get misdiagnosed with that. When people see their skin, they'll think they're a drug user when they're actually not. So when it's when it's just only done as a symptom of the drug use, then it wouldn't be considered a BFRB. One of the qualifications of the skin picking disorder diagnosis is that it's not related to a substance or another medical condition. So just to point that out. But another thing I've learned at the conferences, I go to the TLC Foundation for BFRB annual conferences, and they often talk about that there is some connection between addictions and BFRBs. So you may see someone that has both, that has an addiction to alcohol or another substance, and also has a BFRB. There's also some in the genetic line that it may, if you have a parent who's an alcoholic, you may see someone that has a BFRB. So not only do BFRBs kind of pass down genetically, it also can relate somewhat to the substance abuse. The other things that it is commonly, I guess, commonly seen with anxiety and anxiety disorders. Although I will say there definitely are people that have just a BFRB and no other disorder, because I always want to make that clear, because people often think it's only related to anxiety or only related to OCD, and that's not the case. So there are many people that the BFRB is really their only diagnosis, but you do see it a lot with anxiety disorders and also OCD. It can be kind of have more of an OCD feel to it, like perfectionism kind of thing, like they want their skin to feel perfectly smooth, so they have to pick until it feels smooth if they feel any kind of bump. So it can be similar to OCD. And it has been both trichotillomania and excoriation disorder are now classified under OCD and related disorders. So I also always like to make it clear that they're not the same. So not everyone with a BFRB has OCD. The majority actually don't have OCD. It's just related to OCD. And I guess that was the closest category they could put it in. So you also do see it sometimes along with ADHD. I see that's another common kind of co-occurrence there. So it really can kind of go almost with any disorder, but those are the ones I most commonly see.
Okay. And how do you separate out whether you're looking at an exclusive BFRB or whether it's presenting as part of another diagnostic category? What do you literally diagnose? Do you go with OCD or anxiety disorder and consider that a symptom, the BFRBs as part of that diagnosis, or do you diagnose them both separately?
I would, if they have both, I would really diagnose them separately. I'd say if it's kind of just like the OCD flavor to it, maybe like their only OCD type symptom would be the perfectionism with the picking, and they don't have any other OCD symptoms, I would just diagnose the skin picking disorder. But if somebody is perfectionistic with their schoolwork, or just has other symptoms of OCD, other compulsions that they're doing, then I would diagnose both disorders. So I really just tease out, just like you would in any initial evaluation, going through different symptoms and trying to figure out, which diagnoses they meet the criteria for. And then sometimes it takes longer, like I said, because they won't be very forthcoming. And then sometimes even within, they might come in specifically for a BFRB, and that's the only diagnosis I see at first. And then upon further examining the BFRB, we might see there's some anxiety that's kind of, it can be almost masked by the BFRB, because if they're always, let's say, picking or pulling their hair to reduce the anxiety, in a way, they may not even notice that they're anxious because they're just doing the behavior instead. So sometimes we'll see some underlying anxiety or something else. So just kind of depends. Really, another key thing is that every person with a BFRB or every, BFRB diagnosis is very different. There's not a one size fits all kind of treatment for this, because there's not a one reason why people do this. It can be very, very different. And I think a very important part of the treatment that's often missed with other providers is understanding why the person is doing the behavior. So that takes a very thorough assessment, and it includes the individual tracking their own behavior, which they often don't really want to do, but it really is an important piece. I explain it to them and convince, I guess, or help motivate them to do it by helping them understand that this is probably why you haven't gotten better with other therapists. Many people come to me, said they've seen like 3 different therapists and no one has helped. They've tried different little, I call them like tricks and tips. It might be, different strategies, or here, different little, they say, here, try this, or just cover your head, or, there's lots of different things you can do, and they work temporarily, but nothing is going to be long-term unless you understand why they're doing it.
Tell me about any relationship between BFRBs and self-harm, knowing that some self-harm is more and more has been kind of falling under the umbrella of possible anxiety disorder. How do you see those two interact?
Yeah, so that's one of kind of the misconception about a BFRB, is that people think it's the same as self-harm, or that it, is just another form of self-harm. So first I'll talk about the differences and then the similarities, because there definitely are some similarities as well. But the main difference is that someone who is doing a BFRB, engaging in that behavior, they're not wanting to cause any pain, any physical pain, and actually usually don't feel any pain at all. Even, the only pain they might feel is if they get a skin infection. Once it's infected, they might feel some pain. But actually picking at the skin, pulling out the hair, the eyebrows, things that, others of us might think would be painful, they really don't find pain. Usually they find it more self-soothing, maybe relaxing. So they're not doing it as a way to really cause a pain response. They're doing it, well, this is where it gets into the complicated part. They may be doing it for many different reasons. Like I said, sometimes self-soothing, like a kind of sensory thing, sometimes as a relief of anxiety, sometimes as a habit that they've started, just kind of like, think of thumb sucking. And that generally is kind of self-soothing, but then it becomes such an ingrained habit that it becomes very hard to stop because it's been reinforced through the years. And then sometimes it's more like the perfectionism thing. So there can be lots of different reasons why, but it's really, I've never heard of anyone doing it to, intentionally cause physical pain to try to help deal with their emotional pain. Now, the similarities with self-harm is that, and self-harm is not one of my specialties. So, forgive me if I'm saying things wrong, those of you in the self-harm community, but I do hear similarities when I hear people talking, other therapists talking about treating self-harm, and that, one thing I've heard is that with self-harm, you also want to really figure out why they're doing it, really figure out what is underlying the behavior, and that like the self-harm itself isn't necessarily the main problem, but it's an indicator that something else might be going on. And that's often true with a BFRB. Now, not to say that there's like that the person was abused or that there was trauma or some major other underlying condition, but just that it's maybe a sign that there's some need or a sign that they have some anxiety that's not being addressed, something like that. So I think that's a similarity to self-harm, as well as I understand self-harm can help relieve an emotion that you don't want to feel. So the BFRB can definitely do that too. Just want to make the distinction that it doesn't actually cause the person any physical pain.
Thank you. Thank you for breaking that down. Another thing that I've heard mentioned before is a relationship between skin picking and borderline personality disorder. How has that come up for you in your work? And is that something you've seen
I would
before?
say very rarely. I mean, I would say, I've never counted. I kind of wish I would have like kept some kind of count people. I have had people ask me like, how many people have you seen with BFRBs? I mean, my guess would, be in the hundreds somewhere, which I know is a broad, vague kind of number. But I saw so many people in an intensive program I worked in, as well as individual therapy, over the past 13 years, and then group therapy that I've been doing over the past 6 years. And so in all those hundreds of patients I've seen, I can honestly only think of one person who had skin picking disorder and also borderline personality disorder. I mean, I'd say there's really no correlation. I don't see any correlation. They really haven't found any research connecting BFRBs to trauma. I mean, there's just as much of a percentage of people with BFRBs that have experienced trauma as just kind of the general population. So I don't think there's ever been any connection made. I think that's probably another one of those myths that it's connected when it's really not.
Very good to know. That's why I'm glad we're having this conversation to try to talk about these behaviors and kind of what they're rooted in and how we should be approaching them clinically if they're not within our specialized skill set. So what has been shown to be effective in treating BFRBs?
So, first of all, I want to mention that there is limited research on BFRBs. I think they've had trouble getting research funded. This is something I hear at the annual conference every year, that because, we don't really, or society doesn't really recognize these disorders. They don't recognize the severity of them for sure. There's also not drug companies to fund the research. Because I guess from what I've heard is that they don't find these as serious enough. So there's limited research, but the research that has been done, CBT or cognitive behavioral therapy is the one that there's been the most evidence for. So I couldn't find one like meta-analysis or one study that showed that, but that's just kind of the consensus in the field, is that cognitive behavioral therapy is the most effective. But then it's been broken down into what about CBT, because many of us do CBT, and it's not just the thought challenging or, behavioral activation or those kind of things. What they've found, the first treatment that was developed for trichotillomania was habit reversal training, or HRT. Actually, I take that back. It wasn't developed for trichotillomania. It was used for trichotillomania. You may also recognize people who treat Tourette's or other tic disorders. They also use HRT. It may also be used with other disorders as well. But it was one of the first treatments done for trichotillomania, and it has been successful. So basically what HRT is it involves 3 steps. One is awareness, so building awareness of when the person is doing the behavior. And then step 2 is some relaxation training. It could be, like deep breathing. And then step 3 is a competing muscle response. So the one that was originally developed, and I still teach this to my clients, is clenching the fists. So like tightly, and you can try it now. I always do this whenever I talk about it. So like clenching the fists tightly, and then holding your fists like along your belt, like where your belt line would be, where your belt would be if you were wearing one, and holding that for about 30 seconds to a minute. And what they found there is that the muscles that you use when you're clenching are the same muscles that are used for hair pulling and skin picking. And so it kind of tires out those muscles. And also, it's impossible to be picking or pulling when your fists are clenched like that. So people, I'll recommend people do kind of any variation of that. It doesn't have to be at your belt line. I mean, that's the way I was originally taught, but any kind of fist clenching, often I'll have students just do it under their desk. If they're at school and they notice they're pulling, just clench their fists. And so people have found that to be very helpful, but more recent research has found that alone wasn't helpful, or that gave some symptom relief temporarily, but didn't result in long-term recovery. So what is now the kind of treatment of choice, the type of cognitive behavioral therapy that was developed by the Scientific Advisory Board of the TLC Foundation for BFRBs. And so this is called COMB, so it's capital C, then lowercase OM, and then capital B. And that stands for Comprehensive Behavioral Treatment. And it was developed for trichotillomania. So there was a study by Dr. Charles Mansueto and his colleagues in 1999. And the study was called just that. It was the Comprehensive Behavioral Treatment of Trichotillomania. So most of the research that has been done has been on trichotillomania, because, as I said, skin picking disorder wasn't a diagnosis until 6 years ago. So, so the research is done more on trichotillomania, but almost all, if not all, of the treatments that have worked for trichotillomania also work for other BFRBs. So this comprehensive behavioral treatment, or COMB, focuses on, as I kind of mentioned, what I found so helpful is understanding why, where, and how the individual engages in the BFRB. So using that tracking, and really specialized tracking, to look at these 5 components that they identified that were important to look at. So 1 is sensory, 2 is affective or emotion, cognitive. Then they have motoric, or basically like kind of looking at the motor movements and how automatic it is, and then place or environment. So looking at those 5 areas, making sure that the tracking includes those 5, and really looking at how, maybe sensory issues are involved, like if there's a sensory need that's not being met, or maybe they're overstimulated with one of their senses. It's often the sense of touch, and that may result in the behavior. Or, like I say, it could be one of those others, like an emotional or cognitive. It's generally some combination of those 5, not just one. But then you use what you find in that tracking to come up with a very specialized behavioral plan based on what you find in the tracking. And so they found in that study in 1999 that these interventions were helpful, were more helpful than any of the other, and more helpful than the HRT alone. And it also includes some HRT. HRT is one of the strategies. It's just kind of a more comprehensive plan. Now, a couple other things I want to add. Mindfulness. There has been some research showing that mindfulness-based interventions combined with HRT have been helpful. But there was only one study that I could find that is just mindfulness alone. So this was a study done in 2015 by, I apologize if I pronounced the names wrong, Hareen, Busana, Kusamant, and Filippo. And they did a case study on mindfulness-based cognitive therapy for trichotillomania. And they did find that mindfulness alone may be an effective intervention. So there's some promising for that, which is something I've always used in my clinical practice with people with BFRBs, and have found it to be really helpful. So I was glad to get some of that, see the validation in the research. a couple other things I want to add here. This is a kind of a long section here. But group therapy is another area that not much research has been done on, but many practitioners, many therapists have to. And I myself have been doing group therapy and found it actually more effective than individual therapy for these disorders. And the reason I think is that one of the major symptoms, or I guess ways that BFRBs affect people, is that it causes such intense shame, which leads to isolation and just depression, hopelessness. And when you bring people together with these disorders, they have the sense of relief that they're not alone, that other people do this, and that these other people are normal and just like them, which may sound weird, but most of these people, before I started group, I was hearing over and over again my patients with BFRBs saying, I'm such a freak, and there's nobody else like me. I can't believe I do this. I'm so weird. I mean, nobody's going to ever like me. I'm just this, crazy person. And then, I kept hearing these same things, and I'm like, no, you guys are all like totally normal people. If I wasn't your therapist, I'd want to be your friend. Like, you're totally like a cool person. I didn't say all that to them, but that's what I'm thinking. And so as I kept hearing the same things, and I realized these people need to meet each other. And so I just started putting flyers up for group, and some of my individual therapy clients went into group, but mostly I was getting kind of just new people coming in just for the group. And so I think one thing is that just feeling that they're not alone, reducing the shame and isolation, which is a huge, huge thing, and just helping them feel better. But also I found that the group accountability is higher than or stronger than the individual, or the accountability in individual therapy. So any of us who are therapists or counselors know that accountability is such a big piece of change. You hold someone accountable, but in the group, and the way I've set it up for it to be, a cognitive behavioral group where we set goals, and they're very supportive and nurturing of each other. And so people want to do well to come in and tell the other group members, like, hey, I met my goals, or I did some of it. And or if they're struggling, they want to come in and get that support from others. So that accountability, support, I think, are just so important. And so I use basically a combination of the COMB and mindfulness in a group therapy setting, and I found that to be the most helpful. So there's my kind of long answer of what treatment approaches are effective.
Thank you. I think it's great that you're covering both some specific treatment modalities and methods, but then also looking at group therapy and your own experience of how that's been helpful in, it sounds like, primarily just reducing shame, increasing accountability, and also helping people feel more comfortable with what they've been experiencing. I can certainly see the benefit of that. When those of us who don't specialize either with OCD or with BFRBs, when we see these things in our practices, what do we need to be doing? Like, what are the first steps? Do we immediately refer out? Do people work alongside folks like you who are specialists? Like, what does that look like for those of us who don't have the specialization?
And I think it really depends on the severity of the BFRB. So the first thing I would recommend is first you want to look at if there's any medical risks. So there's a couple things that are really important that we should all know about. So with hair pulling, it is possible to get an obstruction in your abdomen. It's basically, this sounds kind of gross, but like a hairball in your stomach or in your abdominal, gastrointestinal tract, that actually can be deadly if it's not surgically removed. And they actually have a name for it. It's called a trichobazar. And I have not had anyone personally have it, thankfully, maybe partially because I always ask, anyone that is pulling their hair, I always ask, and if it's a child, make sure to tell the parents to ask if they're swallowing the hair. So it's I'd say not common. Like, I'd say more people don't swallow it than do, but it does happen. People do swallow it. And if they're swallowing it repeatedly, it can form into a hairball. And sometimes there's really vague or minimal symptoms until it becomes very dangerous. So if anyone's pulling out their hair, you need to ask if they're swallowing it, and ask it, in a way to not shame them, because they probably feel incredibly embarrassed about that. I usually say, some people swallow their hair after they pull it out. Is that something you do? If they say yes, I know this sounds extreme, but this is what I was taught, and I have sent people to the ER. So you send them to the ER, better safe than sorry, and have them get an ultrasound to check out, just to make sure they don't have any obstruction. So that's with hair pulling, the most dangerous part of it. With skin picking, it can lead to deadly skin infections. So like one of the people I've worked with, she had MRSA in her leg. All started with picking at a mosquito bite. Got so bad that she was in the hospital for 8 days. She had a section of her leg removed. She almost died from this, all from the skin picking. So you want to ask them, do you have any infections? If they're not sure, send them to a doctor again, urgent care or emergency room if they're really thinking it's infected, to get it checked out. So those are just a couple things to mention right away that we all need to be aware of. But then I would say, determine how severe the BFRB is. And I'd say if you don't have any training in OCD or BFRBs specifically, that it is best to refer out for that part. What I tell a lot of therapists, like in the St. Louis area, is that they could continue working with the person if they have other, maybe underlying conditions or co-occurring conditions like anxiety or depression or things that they feel comfortable treating. And then I actually just recommend that they refer the person to my group. So they'll do group with me and then individual therapy with that therapist who identified it. If it is really severe, they may need an individual therapist also who's trained in treating BFRBs. If you are, somewhat familiar with this, I'd recommend really, getting additional training. And it's not really that cumbersome or that difficult. I mean, for me, it was an ongoing process, and that's what I'd recommend, that you continue to be updated, because we're getting new information all the time. So the first place to go is the TLC Foundation for BFRBs, their website, which is just bfrb.org. All the latest research comes through there, all the just articles and advice for parents and all kinds of stuff like that. And then, I think, there's different ways that therapists can get trained as well. So that organization does offer training programs. I believe theirs are on DVDs right now. So you can find that on their website. And then I also offer some online training options as well that I'll mention more about at the end of this. So there definitely are ways to get trained pretty quickly and easily. And I do highly recommend that, because there's such a shortage of providers. So if any of you listening are a new counselor or therapist and you're wanting to expand your practice and get more clients, develop this specialty. It really helped me when I went off into private practice. I mean, there's just, as I said, there's a high prevalence of people with these disorders, and there are, like in the St. Louis area with, over 2 million people in this area, there's 3 therapists that treat these disorders, 3 including me. I mean, it's crazy. It's ridiculous, so I keep telling people is, please learn this stuff. We need more therapists to treat these disorders.
That's a really good point about the specialized training. Thank you for letting us know where we can go in order to get that and get more information and resources. When it comes to things like non-therapeutic approaches, so looking at, say, medications, what's been your experience with that? What have you seen psychiatrists and nurse practitioners do? How does that go in terms of a treatment plan?
So I can talk about that 2 ways. One, from the research perspective, because that's always mentioned at the conferences. So there has not been any medication, either single medication or even combination of medications, that have been approved by the FDA to treat BFRBs. And they've also found that cognitive behavioral therapy is more effective than medication in treatment outcome. However, in 2009, Dr. John Grant, who's one of the scientific advisory board members, he published a study finding that an amino acid called N-acetylcysteine, or NAC for short, did significantly reduce symptoms in about 50% of the people who've taken it. And so in my practice, what I have seen is if somebody has really, severe OCD or significant OCD or anxiety, then that those disorders definitely can help. It's helping kind of the underlying condition. It may help reduce the behavior some, but I have not really seen medication significantly help anyone either. So it's pretty similar to the research. I'd say, there's also, like we talked about, co-occurring ADHD. That medication can be kind of hit or miss because if it's increasing their anxiety, even if it's decreasing their ADHD symptoms, it could make the BFRB worse. Although sometimes it does make the BFRB better. It does help if, if they're like having trouble realizing that they're doing the behavior, or they do it when they get really distracted, or if it's like a kind of impulsive kind of a thing. Sometimes an ADHD medicine can help if the person has ADHD. It's not like it's used just in general for BFRBs. But the NAC, like I mentioned, I have seen some people say that does help, and that's not prescribed, but I always recommend, or, I was told to have people always, talk to their doctor about it. You can get it anywhere, but you need to talk to your doctor to make sure it doesn't interfere with anything else that you're taking, and just to make sure it'd be a good fit for you. So that is the only one really that has seen much promise. Now, again, or I don't know if I mentioned this, they're doing a lot of research now. There's been a big initiative to get more research going on BFRBs. So they're looking at trying to find a medication that will be helpful, as well as looking at like genes and which, genetic, they want to find like specific genetic precursors or genes that are related to BFRB. So hopefully information in the next few years will help us identify a medication that could help. So I always recommend that people see an MD just to make sure that the NAC doesn't interfere or interact with any other medications they're taking, or just to make sure that it's the right fit for them. So make sure to, always have them do that.
That's really interesting about CBT being shown to be more effective than medications.
Yes. And that's really what I've seen in my clinical practice as well. Although I will say one other thing on that is that I think that there's a reputation out there that these disorders really aren't treatable, or that that really nothing works to treat these disorders. And I can see where that comes from, because I think these disorders are very hard to treat. Like when you compare it to the other things I specialize in, anxiety disorders and OCD. I would say that, when people are as a therapist, doing the correct, or the, what evidence shows effective for anxiety or OCD, which is CBT, also using that specific treatment, and if the client is engaged in doing the treatment right, you're going to see like really high success rates. I don't know the exact research, but, I'd say, 90% will get better as far as my clinical practice. With BFRBs, it is a lower rate. You see a lot more dropouts, a lot of people dropping out because it's just too hard. It's just so hard to stop these behaviors. But you also, generally will see that they don't respond as well to the treatment as they, I'd say, do with OCD and anxiety disorders. However, I've gotten more optimistic in the past few years. I think for a couple reasons. One is focusing on what the client's goals are, and really looking at or explaining to them that self-acceptance can be a big part of their goal. And often people really find that even if they don't completely stop the behavior, they can have a great life and really essentially not meet the criteria for the disorder anymore, because their distress about the disorder, their emotional distress significantly reduces to the point where it's not clinical anymore. And there's no disruption in their functioning as long as they can, go out and, see friends and go to school and go to work and go to, go swimming and do whatever they want to do, even if they have some skin lesions or some bald spots, and they can be okay with it and really feel okay, then they don't meet the criteria for the disorder anymore, which is really a kind of a new way. At least for me, it was kind of a mindset shift. And I think for clients, it's also a mindset shift that's really important, because I think it also helps them in their recovery. So it actually helps them reduce the behaviors as well if they can be more accepting of themselves. I also teach a lot of self-compassion, which is, I don't know, I guess it's not really a type of mindfulness or anything, but I teach like self-compassion meditation and help them learn to be kind to themselves and treat themselves like they would treat a friend. And that, along with that kind of just self-acceptance, really, really goes a long way in their recovery from the disorder. And like I said, also then can help to significantly reduce the behavior. So I think that, the CBT, the behavioral treatment, it's mostly behavioral really that we're using, is definitely important. But I've learned in recent years, when I've added that self-acceptance and self-compassion, people have gotten so much better, and they actually stay with treatment because they're feeling better. They're feeling better about themselves, and they're just in general feeling better. So they're more likely to keep coming, whereas others just kind of give up because it's so frustrating. So I just wanted to add that piece as far as the effectiveness of the treatments, and what I've seen.
I can see how there's just been so much shame for these people, and knowing where to start to get it addressed, and the importance of practicing active, kind of what I call gentleness, like gentleness and self-acceptance
Mm-hmm.
of trying to work through something. And I can totally see the complement with CBT there. What are some important first steps in preparing somebody for treatment that's specifically geared at BFRBs?
So generally, I start with finding out, like I would with anyone, what their goals are, like what do they want to see changed, and they'll often say, I want to stop pulling my hair. Okay, and what changes would that, what would that look like in your life? What would change if you weren't pulling your hair? Um, and then sometimes we'll talk about too, maybe not in the first session, but early on, like, would you like to be more accepting of yourself and the behavior? And if you couldn't completely stop pulling, would you, like to just feel better about yourself? And helping them to kind of, if they haven't already identified it, to identify that as kind of a sub goal, or maybe sometimes their main goal is to be, more accepting of themselves and the behavior. And so I think that goal setting is important, and continuing to look back at those goals. Um, and then also, I will have them start a daily mindfulness practice right away. I will sometimes teach them or do a guided meditation with them in the session, and then send them an email of recordings that I've recorded. Or I'll have them do an app. The ones that I like the best personally, and that I recommend, are Headspace, as well as Insight Timer. Those are the two that I recommend the most. And so get them going on, express or teach them the importance of mindfulness and how it could be helpful, and then have them start that right away, because that's going to help just with so many aspects of it. I explained that's going to help with them gaining awareness, which is so important, because so many people are doing these behaviors mindlessly. They have no idea they're even doing it. They might be sitting in class or at work or watching TV or in the car, and they're just picking or pulling and don't even realize they're doing it. And I mean, sometimes they'll just find a pile of hair or blood and be like, oh my God, what happened? And like literally they're like in a trance and don't realize what they're doing, or a trance kind of like state. So awareness, mindfulness builds awareness. Also, it builds ways, kind of helps them with emotional regulation, being able to deal with emotions that may either trigger or exacerbate their symptoms. So helping them um, be able to respond to anxiety in a different way, be able to manage their anger, their depression, or whatever they may be dealing with. Um, and I mean, as probably most of you know, since mindfulness has gotten so popular lately, there's just so many benefits. So I kind of just go through maybe what I think would apply to them if they're struggling with impulsiveness or whatever it is they're struggling with. I mean, mindfulness could almost help with anything. So I don't make it up, but if it fits, then I, let them know that it can help with that. And then say, just give it a try. I like Headspace. It starts with like 3 minutes a day. Just do 3 minutes a day. That's it. You can commit to that. It's like brushing your teeth. And if it's a kid or a teen, I might have them do like a little behavior chart and get rewards for doing it. If it's an adult, I use rewards for adults too, and have them maybe they'll just say, okay, if you keep it up for a week, what are you going to get for yourself? You're going to maybe go to Starbucks or get your nails done, or something like that. Because mindfulness is hard to keep up with. I know for myself, I try to practice daily. I know that's what I need to do, and I'd say I practice almost daily, but it's hard. There's many days where it's hard to fit it in, and it's hard to keep it up. So I talk a lot about mindfulness and teach that at the beginning of treatment. And then the other thing is the tracking, which is so important. They can either use like like paper or a tracking sheet that has those 5 categories on it that I mentioned before: the sensory, emotional, cognitive, motoric, or how aware they are, and then environment, so that they're tracking all of that. Or they can use an app. I know a lot of people don't like to use paper, especially the teenagers. And so there's an app called Trick Stop and another one called, I think it's called Skin Pick. And both of those do a decent job of tracking. They don't have all the categories I want on there. They're not perfect, but better than nothing. It certainly gives us some information to work with. So that's really where I start and have, really gathering the information that we need to then develop a specialized treatment plan.
It sounds like it's a really multimodal response to include some technology, to include mindfulness, and then also, of course, the work that you're doing in the room. Are there any books that you've had people work with or that you've heard about and recommend, either for people to use on kind of a self-help level or as a complement to treatment, that clients might be able to utilize?
Yeah. So the kind of classic, or one of the original books that I refer back to a lot, it's really great for therapists as well as clients, is The Hair Pulling Problem by Fred Penzel. So that's a great kind of almost like, it's not quite a textbook, but almost like it has so much great information. And then for kids and teens, and I sometimes use some of this for adults too, is a book called The Hair Pulling Habit and You. It's a workbook it's designed for like kids and teens. Those are really the two main. I know they're both referring to hair pulling. If I'd say I more often am giving kind of like worksheets or, copying things out of those. And there are many other books listed on the website BFRB.org, and some that are specific to skin picking, but those are the two that I mainly recommend.
Good to know. And with our time winding down, what are some common misconceptions that you find about these disorders that you'd like listeners to know about?
So, some we've already mentioned, but often people think BFRBs are really rare, and they're, that doesn't affect anyone they know. They'll say like, oh, I don't know anyone that does that. But as I mentioned, 1 in 25 people do this. And that's just like documented cases. The other thing, it could even be higher than that because so many people don't get treatment or don't even know they have the disorder. Another common misconception is that it's only girls or women that have these disorders. And that's really not true. We see people of all genders with these disorders. In childhood, actually, they found that it's about equal as far as girls and boys. But then by adulthood, it actually is. There's reported cases are about 75 to 90% female. However, again, that's the reporting. So this could be because women are more likely to get therapy. It could be because for women, hair and skin is in our society is kind of deemed more important, and it's more important to look good. It could also be, if you think about it, men who have bald spots, they can just shave their head, and that's socially acceptable to have a shaved head. Women, not as much. So there's, several, I think, factors that may go into it that may be distorting this some. But I definitely see it, in all genders. Another misconception is that a BFRB is just a bad habit, and it's not really a disorder. So as I explained, these are, complex psychological disorders. It is not just a habit. It sometimes can have a habitual nature to it. But that's just one part of it. It is a lot harder to stop than most habits. And then kind of related to that, another misconception I often hear is that people with BFRBs don't want to stop the behavior. People kind of think that if they could stop, they think, well, why don't they just stop? They think it's so easy to stop, and that they probably just want to keep doing it if they're doing it. That is really not true. Most people with the disorders really desperately want to stop. They are so, embarrassed and feel guilty about doing it, and frustrated with themselves, and the shame and isolation that I mentioned. So the consequences of it. Yet it is similar almost to an addiction or a compulsion that they literally feel that they cannot stop. And so they certainly would like to stop, the majority of them. Now, you will see some kids and maybe younger teens and sometimes adults, but more often you'll see this with kids, is that they actually don't want to. They don't see any of negative implications of it. They say, well, it's fine. I don't care. Nobody's teasing me. I don't care. I don't have eyebrows or eyelashes. It's no big deal. And in that case, I would say to the parent, if there really is no medical issue, it's not any health concern, if it really is fine with the kid, then it's not a disorder. It's, the parent generally will have issues with it. And I say that's kind of something then the parent needs to work on. And if the kid at some point wants to work on it, great. But if they don't, or you can't force a kid to work on this if it's not causing any problems for them. But for the most part, people with BFRBs really do want to stop, and they've generally tried so many things, and that's why they're so frustrated, because it's so hard to stop. So those are the main misconceptions that I hear about.
Thank you. Thank you for clarifying those. I think the gender differences are important for us to know on the clinical level, and also keeping in mind what other variables might be affecting that, like so many diagnoses that we see more commonly in men or in women, and why that might be. I think you brought up some really good points. So, Laura, we are wrapping things up right now, and I'd love to hear from you. How can people learn more about you, learn more about the work that you do? You've pointed to some great resources today, but if you could restate some of those for our listeners in case they want to look those up. I think you have such a wealth of knowledge to offer, so please share some of these things with us.
Sure. So just to learn more about BFRBs in general, I think, the website bfrb.org, which is the TLC Foundation for BFRBs. That's their website. They are a nonprofit organization dedicated to promoting awareness and education on BFRBs. So there's so much information on there. then I also do provide some online training and coaching on these approaches that I've talked about. And so the best place to go to get more information from me is I actually have a private Facebook group. So you have to ask to join. And that also helps so that clients can join as well as therapists and parents, and it can be confidential. It's not therapy, so I wouldn't actually, say confidential, but it's private. No one knows you're in the group unless you're in the group. And so that group is called Overcoming Skin Picking and Hair Pulling, and then a : help for BFRBs. So you can just search that up in Facebook and then ask to join. You could also feel free to email me if you have any questions, or if you want to join my mailing list to get to be on the list to know when I'm offering more free trainings. I often do free webinar series. So my email address is lchackes, which is CHACKES @mindfulstl.com.
Wonderful. Thank you again, Laura, for your time today. I think you've given us all a lot to chew on and think about, and probably not chew on hair. But thank you again for your time, and we will definitely look up those resources.
Thank you. It was my pleasure. Thank you so much for having this topic. I'm very excited.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.